Well, we're going to move on with our next speaker. Um, I had the pleasure of working with Dr. Mohboubi when I was at the House Clinic. He's a wonderful physician. He's a board certified neurotologist and skull-based surgeon right now at the House Clinic. He completed his residency at UC Irvine, followed by a clinical fellowship in otology and neurotology at Hossein Clinic in UCLA. Dr. Mohboubi, there was a typo on this, has published extensively in national and international audiolaryngology journals, authored several book chapters in neurotology and neurosurgery, and he's a member of the American Neurotology Society. There's probably a lot more to that, but that was all like the internet. Okay, take it away.
Thank you so much for the kind introduction and for having me this evening. Let me see if I can share my screen successfully. All right, do you guys see my screen okay?
Yes, we
Alan,
can see it.
Okay, perfect. Okay. All right. So thank you so much for having me this evening. I will be talking about Meniere's disease, and we're going to go over its clinical and audiological features and management. This is a condition that I'm sure all of you have been dealing with, and you probably have had patients that have been suffering from this condition. So as we go through the slides and kind of talk about this disease, feel free to start asking questions. I'm not sure if the Q&A will be open at the end or not, but if there's any specific questions as I'm talking, please feel free to type it, and then we'll be happy to kind of take questions at the end, or I guess we can even do it during the talk, either way, whatever you guys prefer. I have no disclosures, so we're going to start by a case presentation, and then we're going to go over kind of the history of Meniere's disease, its epidemiology, pathophysiology, diagnosis, treatment, and auditory rehabilitation. So very recently, a patient presented to my office, a pretty classic case, a 47-year-old female. Was complaining of a 1-month history of right-sided ear fullness and hearing an ocean type noise. And she also said that she has had 4 episodes of dizziness that she described as a spinning sensation, and they would last for minutes, and the longest one was almost 2 hours. And one of them was at the onset, and she also took like a seasickness medication, which helped at the time being. She was a pretty healthy woman otherwise, and only had a history of C-section in the past. So we examined her. This is not her picture, but essentially depicts a normal ear exam, which shows the external auditory canal and the tympanic membrane. And I'm sure many of you, when you're checking the patient's ear, have seen this picture before. So her ear exam was normal, and then we obtained an audiogram, and this was her audiogram. It showed a drop on the right side in the low frequencies, and the pattern was pretty much sensorineural hearing loss, and had this kind of an upsloping feature, and the rest of her hearing thresholds were normal, and luckily her word understanding was also intact at the time that I saw her. So this would be a pretty classic presentation for a patient with Meniere's disease, and they're not always that classic. Sometimes they have vague symptoms, or sometimes they've had a hearing loss or a clogged ear, and by the time they come to see us, they say, "Oh, it improved," and that obviously is one of the challenges of diagnosing this condition. But for many of you who have seen these patients before, or those who haven't, if you ever notice a pattern like this is pretty classic for Meniere's disease. For age-related hearing loss, for example, you would expect to have worse hearing in high frequencies, not in low frequencies. So anytime a pattern like this is seen, usually a Meniere's disease is suspected. So in essence, Meniere's disease is a clinical syndrome, and the main features of it are episodic vertigo or dizziness, and usually they need to have at least 2 episodes to be officially diagnosed with certain criteria that we will go over those shortly. They need to have a fluctuating hearing loss, and often they're going to have a tinnitus, which most often is described as a low pitch noise or an ocean type noise. But sometimes they can just have a regular ringing or buzzing tinnitus. So that certainly cannot rule out the presence of Meniere's disease. And ear fullness or pressure or sensation of having a clogged ear or feeling like they're on an airplane and the ear does not want to pop is very common among these patients. We don't know exactly what causes Meniere's disease, believe it or not. We know kind of how it happens, but we don't know what causes it. Why does someone in their 20s come to us with Meniere's disease? Some of these patients present to us in their 40s or 50s or 60s. So we still don't know what actually triggers it, but we know that the central pathophysiology is the endolymphatic hydrops, which we will go over shortly. So Meniere's disease is actually named after a real person, a physician, and this was a French physician that was named Prosper Menier, and he was the first one to propose that there is an inner ear condition where people can have vertigo and hearing loss, and at the time, this was considered controversial because it was widely accepted at the time that dizziness and vertigo occurs at the brain level and not at the inner ear level. And obviously, as he presented his ideas and published it, and eventually this disseminated within the medical communities and within the otology community and physician associations, then a lot of other doctors noticed it and eventually it became widely accepted as a condition. And the term actually was introduced into the medical terminology in the late 19th century. And at the time, as you can imagine, there were not many treatment options available because we did not know much about the pathophysiology of conditions at the time. So they would do dietary restrictions or bloodletting treatments at the time, and essentially, I guess, accept the dietary restrictions that we will go over with that in a minute, in a few minutes. The rest of those historical treatments are essentially obsolete at this point. So the incidence is around 50 to 200 per 100,000 adults. So it's not a very common condition. So if you ask friends and family and extended family, probably nobody has had it, or sometimes you may find one person who has it. But as an ear surgeon and an otologist, we do see this pretty commonly. There's pretty much no clinic date that we do not have a Meniere's patient, whether it be a new patient or a follow-up patient. Although the peak incidence is between 40 and 60 years of age, it can affect patients of any age. I've had patients in their teen years, around 18 years old, and I've had patients presenting for the first time in their 70s. So certainly can affect patients of any age. So anytime a patient presents for a hearing test, this should always be in the back of your mind, regardless of their age, if they have either a pattern that could be suggestive of Meniere's disease, or if they describe a fluctuating hearing loss or associated dizziness. There's a slight female preponderance, but both sexes could develop this condition. It is often unilateral, but it can, in a small fraction of patients, progress to involve the other ear. A very small minority, maybe probably like less than 1% of patients can actually present with bilateral Meniere's from the get-go, but for the most part, patients have this only on one ear, and they can later down the line, like 10, 15, 20 years down the line, they can then get it on the other side. And I would say that this, my personal experience has been that this is less than probably 5% of all Meniere's patients, but it is possible. And oftentimes, as patients develop the hearing loss from this condition, they're very concerned that, what if this affects my other ear? So when they present to you, they might even ask you that, is there any chance this can affect my other ear? And I always kind of give them reassurance that even though it's possible, the chances of it are very small. And most of these cases are sporadic, meaning it's the only person that develops it in their family, and It usually does not run in the families. So as far as we know, it's not a hereditary condition. However, there have been case reports of familial clustering. The most likelihood of a kind of a familial condition or a hereditary condition that I have seen has been one or maybe two patients in my entire career that they said like their father also had it or their brother also had it. But for the most part, these patients are the only person who has this condition in their family. So, about the pathophysiology of the Meniere's disease, we need to first kind of review the anatomy and physiology of a normal ear and how we hear. And as all of you are familiar with the workarounds and mechanics of the hearing system and the auditory system, we have our auricle or pinnas that collect the sounds and direct the sounds towards the external auditory canal, and they then hit the eardrum. They cause little micro vibrations, and the ossicles transmit these vibrations to the inner ear or otic capsule. And inside the inner ear, you have the cochlea, you have the vestibule and the semicircular canals. And inside the inner ear, you essentially have three chambers within the cochlea that are connected. At least the two of them are connected. You have the scala vestibuli, scala tympani, and the scala media that is in the middle. And it contains the organ of Corti, where the action happens when the sounds come to this location. Obviously, the vibrations of the inner ear fluid results in vibrations and movements of the hair cells, and then that is translated into a signal which the nerves take towards the brain. So what happens in Meniere's disease is, or as far as we know, is you develop what is called endolymphatic hydrops. So this is a pathological slide, and these are usually from postmortem studies of patients who donated their body to science, and we've witnessed the hydrops in a great deal of those patients. So these are patients with Meniere's disease, and and this is from the same patient that, and these are kind of the slices from both cochleas, one side normal, one side with Meniere's disease. And if you look at the picture on the left side, the blue part is the scala media, and that is how it's supposed to look. And if you look at the picture on the right side, you can see the dilation of the scala media. And this is indeed called endolymphatic hydrops. And in the medical terminology, hydrops means that if you have an organ or a part of the body that normally contains fluid, if you have too much of that fluid, then that is called hydrops. And that is the central pathology of the Meniere's disease as far as we know. Um, Now there is a new MRI protocol that some places can do where you can actually do a delayed contrast protocol and actually observe the hydrops in Meniere's patients. But because we cannot detect it in everyone, it is not a part of the diagnostic criteria. But these days, not infrequently, we get asked by the patients, I've heard about this MRI that can show Meniere's. Can I get that? I want to see if I have Meniere's disease. And as we will go over that in a few minutes, it is not a part of the diagnostic criteria, but I have ordered it in a small percentage of patients. If the patient really asks for it, then we have nothing against it, because we usually recommend an MRI to rule out other conditions, and this way, at least we can detect the hydrops. And the other, I would say, benefit of that would be if we're not really sure if it's a patient that really does not fit in the box, does not meet all the criteria, and we are debating whether it's Meniere's disease, I think that could potentially help. But again, it is not a part of the diagnostic criteria. And I always tell patients that it might actually be easier to just start you on the treatment if you're thinking about Meniere's disease and see how you respond. So this slide, again, kind of highlights the features of the Meniere's disease, and it shows that how the hydrops can also extend into the vestibule and the semicircular canals, and that is essentially what happens in Meniere's disease. And by involvement of the vestibular system, then vertigo can occur along with the other signs of the Meniere's disease. So as I mentioned, the underlying etiology is not known, and we think this has to do with increased endolymph volume within the scala media that results in endolymphatic hydrops. There's also another theory that says that the hydrops alone is not just the problem, but it can result in rupture of the Reisner's membrane, and you can have a little bit of a mixture of endolymph and perilymph. And endolymph is the fluid that is within the scala media or organ of Corti, and perilymph is what actually surrounds it and flows within the scala vestibuli and scala tympani. So that's another theory that some people believe that could be the cause, and by that mixture, you essentially get high volumes of salt with or sodium within the scala media. So the perilymph, in essence, has a composition similar to blood serum, meaning it is high in sodium and low in potassium, and scala media is very much so similar to intracellular fluid in the sense that it is high in potassium and low in sodium. So what results in that in the lymphatic hydrops, as far as we know, and the way we treat it is by thinking that the salt or sodium volume goes up within the scala media, and the diuretic that is given as a treatment is essentially meant to kind of reduce that. So that's kind of where this theory comes into play. There are other theories of how Meniere's disease happens, but as of now, none of these have been absolutely proven. But in some patients, actually, you could argue that these would be more likely. Some people think about impaired drainage uh, issue within the in the lymphatic system. Some people think it's an autoimmune response. This is at least the part that we think happens with delayed contralateral Meniere's or hydrops, meaning the patient who has, let's say, a right-sided Meniere's disease for uh, years, and sometimes it could still be active, but most often it kind of goes into remission. We never see them. They come back 10, 15, 20 years later, and now they have it on the other side. So in these patients, we think that there's certainly an autoimmune component to it. And also in the patients who present with bilateral Meniere's disease, that is also thought to be potentially due to an autoimmune response. And you might have heard or be familiar with the term called autoimmune inner ear disease. It is a loosely defined condition. In essence, it needs to or patients need to have bilateral progressive hearing loss with frequent episodes of sudden hearing loss that are responsive to steroids, meaning I've had at least a dozen of these patients. When you start them on steroids for the sudden hearing loss, their hearing improves. Within a week or two, when they come off of it, the hearing drops again, and then we offer them injections, but they're kind of like a frequent patient that they need multiple injections or multiple rounds of steroids, and we would then send them to a rheumatologist. But there's really not a test to prove that, and oftentimes they do like a full rheumatologic panel, and all of it comes back as normal. Or even if you find like one or two abnormal lab results and you send them to a rheumatologist, they might still not treat them because they kind of go by criteria within their scope of practice too. So if you don't, for example, if let's say you have an ANA positive result that is seen in lupus disease, but if you don't meet the criteria for lupus and you have no other symptoms, they essentially will not treat you. But there are some rheumatologists, especially those who take an interest, that would then try some alternatives to steroids, and that would be the mainstay of treatment for these patients. There's also an association with migraine, and that has kind of gained a lot of popularity in terms of at least the research studies that have come out, and you might have noticed it too in your patient population. A lot of these Meniere's patients have migraines, either a history of it or kind of active migraine symptoms when they develop Meniere's disease. However, not every Meniere's patient is going to have migraine, and not every migraine patient is going to have the Meniere's disease. So the question is there a common root that causes both, or again, whatever's causing Meniere's is also causing the migraine, or some sort of a connection there? But in essence, we do see that association a lot in a lot of patients. And there has also been theories about viral triggers or viruses causing it, and some people who would treat resistant cases of Meniere's with antivirals. Sometimes you can see improvement, but one of the challenges in studying and treating Meniere's is that this is a chronic condition, and B, a fluctuating condition. So sometimes when patients get better, as much as we might want to take credit for the treatment, it might honestly be just the kind of the disease process, and it can go into remission and become dormant, can come back shortly after. Sometimes it can be even dormant for a whole year or sometimes years, and then it can come back again. But this is also one of the theories out there in terms of what causes Meniere's disease. So it is still considered a clinical diagnosis, meaning there's no established test or imaging study to prove whether a patient has Meniere's disease. If you check all the boxes for the criteria, that's what you have. If you check one or two of the boxes, then we still say it's a probable Meniere's, and we would essentially start treating them if there's no other condition that could explain their symptoms. And the only other, at least for now, semi-established study would be that MRI with the special delayed contrast protocol. There have been a lot of research and a lot of studies about using ECOG and other audiological testing, but at least as of now, none of those are being ordered on a routine basis. And because this is a clinical diagnosis, it is imperative to exclude other identifiable causes. So we'll go over that in a minute, but for actually establishing the diagnosis, the mainstay has been the criteria developed by the American Academy of Otolaryngology and Head and Neck Surgery. So to have a definite Meniere's disease, a patient needs to have two or more spontaneous attacks of vertigo, which is defined as a spinning dizziness, each lasting between 20 minutes to 12 hours. There needs to be audiometrically documented fluctuating low to mid-frequency sensorineural hearing loss in the affected ear on at least one occasion before, during, or after one of the episodes of vertigo. There needs to be fluctuating oral symptoms, which is hearing loss, or could also be even tinnitus or ear fullness in the affected ear, and other causes need to be excluded. And then there is a category of probable Meniere's disease, and these patients, they need to have at least two episodes of vertigo or dizziness lasting 20 minutes up to 24 hours. This is one of the differences between definite and probable Meniere's, is that for the definite, it needs to be up to 12 hours, but for probable Meniere's, it would be up to 24 hours. And also the same thing, fluctuating oral symptoms in the affected ear. But for probable Meniere's, they don't necessarily need to have an audio metrical evidence of a hearing loss. So this is kind of one of the challenges, especially those patients that it's not clear cut whether it's Meniere's disease or not. And sometimes they essentially have Meniere's, but we just haven't been able to catch it, meaning they have some vague dizziness or vertigo episodes here and there, and they say my ear gets clogged or my hearing feels like it's down, or I hear a low pitched noise. But by the time they make the appointment, go to see their audiologist or come see us, the test is normal. So I've had at least a few of these patients that I have been able to catch it either by trying to bring them in for a same-day hearing test. I just tell them like, hey, call our office as soon as you feel like your hearing is down, and we'll try to get you in that day or the next day. And a few of these patients, I have been able to have them to use home hearing tests. There are a few apps on at least iPhone, and I've checked there's some of those are also available on Android phones, and you essentially use a home test. I tell them to like get one today or tomorrow when it's a good day, and then get one test at home on a day that you feel like your hearing is down, and they would just email me the screenshots. And at least a few of these patients have been able to catch that, meaning we see it kind of beautifully, like the drop in the low frequencies, and it kind of helps with the diagnosis. Because once we diagnose someone with Meniere's disease, they need to be on medications for long term. So we really want to make sure we do our due diligence before we start someone on treatment. So as I mentioned, we need to exclude other identifiable causes. So a detailed history is certainly important to rule out certain other conditions. If patients have only had one bad episode of, let's say, someone just had a sudden onset of vertigo for 2 hours yesterday, and then their hearing was down, and they actually come to the office and their hearing is actually down. Some patients are like that. They're really on top of their health. They try to kind of call us, or they've been to our office before for something else, and they kind of get in sooner. So to officially diagnose that patient with Meniere's, they need to have at least two episodes. So if they are presenting in between the first and second episode, then you cannot diagnose it. So at least in the beginning, if there is any doubt, we would just call it labyrinthitis. It's just sudden onset of vertigo and hearing loss, most often caused by viruses. We would treat it with steroids. But even if they get better, I mean, if it starts fluctuating in their follow-up visits, then pretty much the diagnosis is established. But sometimes they get better, and I always tell them, hey, when you go home, if this happens again, you got to come back. Then it's not a virus. Then it's not labyrinthitis. Then it's most likely a Meniere's disease. So, point being, if they present for the first time and it's been their first attack, then sometimes a labyrinthitis attack could be mistaken. Then we need to ask them about what medications they've been on. If, for example, they recently completed chemotherapy, or let's say they had a really bad intestinal infection, they were admitted to the hospital, they were given multiple rounds of antibiotics, they had sepsis, they were in the ICU, they don't know what they were given. So sometimes it could be an antibiotic that may have potentially damaged their hearing. So that is certainly important to be ruled out by taking a detailed history. And we kind of went over the autoimmune inner ear disease and also benign positional vertigo. Some patients, they may have not had a hearing test in a while, so you don't have a baseline. And let's say they already have like an asymmetric hearing loss. Now they have benign positional vertigo. They keep getting episodes of vertigo. Now, technically, it needs to be, again, for official diagnosis, it needs to be at least 20 minutes, but some patients don't fit in that box, and they just have shorter episodes. So that is always in the differential. And then obviously we would do an Epley maneuver and tell them like, hey, if this comes back or hearing fluctuates, then it's not BPV. But at least in the beginning, sometimes it could be mistaken for a benign positional vertigo. Then we would examine the patient to obviously rule out infections, such as, for example, Ramsay-Hunt syndrome. And you would see kind of blisters or rashes around the ear, or if the facial nerve is not involved, then it would be called just herpes zoster oticus, which can cause hearing loss and vertigo, similar to Meniere's disease. And again, we would be looking for evidence of like blisters or rash, and it's almost like a shingles of the ear and the inner ear. So that would kind of help with the diagnosis. An acute perforation can sometimes manifest like this. If someone, let's say, they were playing with a Q-tip or bobby pin, and then their uh, spouse ran into them, and then they hit their eardrum, and then that acute injury can sometimes result in vertigo and hearing loss, which could even be fluctuating if it results in a purulent fistula. And benign positional vertigo could also be ruled out at this stage, because we would do a Dix-Hallpike test, and if you see a classic geotropic nystagmus, then kind of your mind shifts more towards like a benign positional vertigo rather than an actual Meniere's disease. Lab tests we do not routinely order, but if there is any concern for some infectious disease, based on patient's history, or if they've been, to areas endemic for example, Lyme disease, then, or the presentation is unusual, then we might sometimes order lab tests to rule these out. But for the most part, we wouldn't routinely order lab tests. MRI is 100% recommended and essential to rule out pathologies such as vestibular schwannomas or acoustic neuromas, and also to rule out stroke, again, especially when this is just the onset of the Meniere's disease. Oftentimes, patients have a really violent attack and they end up in the ER because they don't know what's going on. It's never happened to them. They call 911, they end up in the ER. Usually they come to us at least having had an MRI in the office, but just actually very recently I had a patient that, for luckily, she had made an appointment to come talk to us about tinnitus, and then she happened to have an attack that exact morning. So we just sent her directly to the ER to get an MRI, because you never know, it could be a stroke, and those are time sensitive. So it certainly needs to be ruled out. Vestibular schwannomas obviously are not as urgent, but we still would recommend MRI in all of these patients to evaluate for presence of this. It's pretty easy to rule it out, and usually they need to just do one MRI, and if it's negative, then that's not what they have. Audiogram, as we kind of discussed, is the cornerstone of diagnosing Meniere's disease, and these patients will need a lot of audiograms during their lifetime. And certainly, every time they come to see us, we would obtain an audiogram. Now, each physician might have a different protocol. For myself, the way I do it, or I treat Meniere's disease, I usually like to, if it's established diagnosis and there has been nothing acute, I start them on the medications, and I would then have them come back in a month. We'll assess the response to treatment. We'll repeat the hearing test, see how it looks. And if they're still having active symptoms, I'm adjusting their medications or trying something else. I would then have them again come back every month. At least we can get to a point that their symptoms are well controlled. And if they ever come back in a month and hearing has been stable, symptoms are controlled, then I space it out to 3 months and then to 6 months, and then eventually just once a year to refill their prescriptions. But again, upsloping low frequency hearing loss is in essence high drops and if associated with vertigo, Meniere's disease, unless proven otherwise. Some of these patients also come to us with a VNG, either ordered by their primary care physician or outside ENT, or sometimes they just come to us asking for VNG. It is a good complementary test for sure. However, as I mentioned, it's not a part of the diagnostic criteria. So we can certainly consider doing that. But as you guys are familiar with VNGs, it's a pretty involved test, and especially if they're during the active phase of the disease with a lot of vertigo episodes, they probably don't like to do the calorics to get vertigo during that because they're actually trying to not have vertigo. So, but it can certainly be done, and you can usually see hypofunction of the vestibular system on the affected side, and also they may have some degree of positional nystagmus. In my mind, a VNG would be useful, again, if a patient has an unusual presentation or if they're really not responding to treatment, and we're actually now questioning the diagnosis of Meniere's disease. I think VNG could be very useful in that situation, because if that comes back as normal, that would be kind of one more point or arguing against a diagnosis of Meniere's disease. But I think it's certainly an important tool in managing these patients, but just not essential for diagnosis and management or of at least the routine patients that we see. So the natural history of Meniere's disease is that it's a progressive condition, and it is fluctuating in nature, and each patient is different. Probably don't have like more than a few patients with Meniere's that their history and progression or fluctuations are the same. There are patients that they just have had like 2 or 3 episodes. We see them right away, start them on treatment, they respond very well. Hearing goes back to normal, never comes back. And there are patients that it goes into remission, maybe weeks or months later, it can come back. And there are patients that they're fine for years. And then again, 10, 20, 15 years down the line, the same ear could happen again, or it can go to their other ear. So each patient is different. And so it is often unpredictable. And this is the part that makes the management a little bit complex and challenging, because as you start treating these patients and they get better, it is really hard to say whether it was the medication actually that helped stop their symptoms, or is it because their Meniere's was just going to get better anyway. So oftentimes the question comes up by patients, or sometimes audiologists contact us. Like, for example, let's say they're seeing a Meniere's patient who's been in remission for, let's say, 5 years, and they see our audiology department for hearing aids, and they just ask them, hey, can you ask the doctor, do I still need to be on my medications? And it's always a tricky question. And a lot of these patients are long-term on the medications, and we'd like to keep them on them because it kind of helps stop it. But if someone has not had any attacks or symptoms or any fluctuation in hearing for at least a year or two, and if they want to come off of it, or if their other doctors are concerned, I always tell them we can give it a shot, and obviously there's always a chance it might come back, but it could be considered. And we have had patients that they come off the medications, or sometimes they just do it on their own because they've been fine for a while, and then it doesn't come back, but there's always a chance that it might come back. And I always advise them that if this does happen, you want to contact us right away, resume the medications, and then if that is the case, then we would certainly keep you on these medications long term. So in terms of symptoms, the most prominent feature is vertigo. Now, as patients with Meniere's are managed, or if even if their disease is resistant and they keep getting episodes despite being on treatment, one good thing about the natural history of it is that over time, the vertigo episodes can subside, because each time technically kind of damages the vestibular system. We can sometimes detect it on VNG that they have 40% or 50% weakness on the affected side, and at some point it can essentially go all the way to like 90 percent plus or even 100% loss of function, and that will actually result in resolution of their vertigo. Now, they might still have imbalance or minor dizziness with turning head or certain body movements, but for the most part, vertigo episodes can go away even on their own if left untreated. However, if you have seen or have been dealing with patients with Meniere's, you know that their vertigo attacks are sometimes so severe that they, even if they've not had it for a year or two, they just fear stopping the medication and experiencing it again. So in some patients, it is really severe. Now, exceptions do exist, and then we'll kind of go over some of the surgical options that we would offer these patients with really resistant or persistent vertigo, but it is the most debilitating symptom is in these patients. Oftentimes, as we are managing them, and let's say they keep having episodes of vertigo or their hearing keeps fluctuating, oftentimes they say, "Doctor, I don't care about my hearing, my other ear is fine. Just make the vertigo stop." So this is the most debilitating symptom affecting them. Now, as I mentioned, when they're asymptomatic, sometimes it is unclear if it's treatment that is keeping it at bay or whether the disease is in remission. And in most case scenarios, we probably don't want to find out and we want to keep them on the medications. And then some of these patients, as I mentioned, can have simultaneous migraine. So it is not uncommon to have a Meniere's patient that they've been fine, let's say for months or a year, and then now they're having vertigo again. And we start talking to them, their hearing test is normal, there's no change, or even if, let's say, they had a little bit of a loss, it hasn't changed at all. They're not complaining of a clogged ear, there's no ear pressure, and but they keep getting vertigo, or sometimes they just have this kind of vague episodes of dizziness that can last for minutes to hours or a whole day. They feel like they're on a boat, or they're feeling they're losing their balance. And then if you kind of start questioning them, then they might say, yeah, I've also been experiencing some headaches or some motion sensitivity or light sensitivity, or they might even actually have a history of migraine. And if you ask them, they say, yeah, my migraine has also been active. So in these situations, then we start suspecting vestibular migraine as potential culprit. So if they're already on the Meniere's treatment, then we would start treating them for vestibular migraine. And if their symptoms subside, then essentially that's what they had. They unfortunately had both Meniere's disease and vestibular migraine. Some people think these two are the same, and as you might have attended other meetings or listened to other neurologists talking, some people think the vestibular migraine and Meniere's are the two sides of the same coin. Some people think they're completely unrelated. I think there is some connection personally, but I agree that these potentially are two different entities. And if a patient presents with both, obviously we'll treat them for both, but we tend to treat them individually, meaning if it's more of a vestibular migraine, we would treat it as such. And if it is more of a Meniere's type picture, then we would treat them for that. Another kind of symptom, or I guess one subcategory of dizziness, is drop attacks. And oftentimes, patients describe it as a sudden fall without warning, no loss of consciousness. They didn't trip. Let's say they were sitting at a dinner table, or they were just standing talking to their friend, and they feel like someone just pulls them to, let's say, the right side or left side, and it just pulls them to the ground and they just fall. This is also another debilitating symptom, and some Meniere's patients will have multiple of these drop attacks, which is very scary to them. And we still would consider it kind of a subset of the vertigo or dizziness, but it is a little bit distinct than just having a spinning attack. So this could be experienced during later stages of the Meniere's disease, and it's not present in every patient, but certainly I've seen it even in patients who initially presented to be diagnosed with Meniere's disease. But for the most part, it can happen in later stages if it is not treated well. So hearing loss also is fluctuating in the beginning, but as the disease progresses, a lot of these patients will have a permanent hearing loss. So when I initially see these patients when they had, let's say, normal hearing, and they started to have kind of like a drop in the low frequencies or some fluctuation, initially it would sometimes go back up to normal, even with or without treatment. And I always tell them, if it goes back up, great, that's our goal. But sometimes it doesn't. And if you, let's say, start them on the treatment, you do steroids and all that, and it's been a couple of months and it's not going back up, then unfortunately that drop in hearing would be their new normal. So the goal in treatment would be to preserve their hearing at that level, so at least it doesn't drop any further. And sometimes we can achieve that, sometimes we don't. But uh, in essence, we would be considering a drop in hearing essentially permanent if after a couple months it hasn't resolved with the proper treatment, and that would become their new baseline. So the drop in hearing could be both in volume and clarity, meaning sometimes, just like the case I presented, it could be just a drop in hearing thresholds with intact word recognition score. Sometimes it's decline in clarity, or sometimes both, meaning, uh, let's say the hearing hasn't changed, but all of a sudden their word recognition score dropped from 100% to 80%. So that would still can be considered a fluctuation in their hearing. There's also another complaint by patients that they hear sounds distorted, or some of these patients are musicians or they're audiologists, or they know kind of their pitches very well. They would exactly tell us that, hey, yeah, I feel like I've lost hearing at like 500 hertz or 1,000 hertz. So they would actually be able to say that, or they would say, yeah, everything just sounds distorted. So I feel like I'm hearing through a broken speaker. And you look at the hearing, it looks the same. But I think that is also a part of the high drops picture. It just depends on how much pressure it's putting on the hair cells and how much damage it is causing. So if someone's hearing is stable, but they're complaining of a new onset of distortion, I think that should still be considered as a fluctuation in hearing and treated accordingly. So about 82% of these patients roughly will eventually develop moderate to severe sensorineural hearing loss. And in some patients, it can actually result in a profound loss in the affected ear, even if we do everything for them, unfortunately. So if you look at kind of these serial audiograms, this is kind of very typical of a Meniere's patient as you keep seeing them over months and years, meaning they might initially present with a drop in low frequencies, treat them, it goes back up, happens again. At some point, it becomes their new normal. And as we keep seeing them over the years, it can fluctuate, but it can kind of eventually kind of drop and drop, and their word recognition can also approximate 0%. It's I guess in one way to look at it would be, almost looks like the stock tickers, but instead of kind of fluctuating and going up, this fluctuates and comes down. And eventually, when they get to the severe to profound range with, very poor word recognition score, then at that point, oftentimes their vertigo episodes also stop, but it's not 100%, meaning there are patients that they could lose all hearing, but vertigo is still ongoing, and there are patients that they could lose all balance function despite still having some reasonable residual hearing and word understanding. So even though they don't always go hand in hand, but it is very common for an end-stage Meniere's disease to have damaged both organs of the inner ear. Tinnitus is also a very common complaint, and especially as the hearing drops into severe to profound range, this can become their main complaint. By then, they've they've coped with the diagnosis. They already know what it is. Maybe even their dizziness or vertigo is well managed. But as their hearing drops, let's say to severe range, their word recognition score is only 24%. They can't really use a hearing aid at that point, but then tinnitus becomes the major problem for them. Now they have this loud, either low or high pitched noise that just constantly, is heard by them, affects their sleeping and everything. And they always kind of come to us asking, all right, what can I do about the tinnitus? I don't care about the dizziness anymore. That's totally fine. My hearing is gone. I'm used to just hearing through my left ear, but I just want this tinnitus to be gone. So in late stage diseases, this can actually become the most prominent feature of the Meniere's disease. And as I mentioned, the description of a low-pitched tinnitus is more typical. Usually patients describe it as like an ocean noise or a seashell noise, but it could also be high pitch, again, depending on which part of their hearing spectrum has been affected. And also the tinnitus itself, even if it's not too bad, it can actually worsen during the attacks. So if someone says that, yep, let's say they have a diagnosis of Meniere's disease and they feel like they have a vertigo attack, and all of a sudden their tinnitus gets like super loud, it is pretty much fair to assume it was a true attack and their hearing probably got worse at the same time. And once we start them on treatment, this would also be the most difficult symptom to manage, meaning oftentimes we can help them and stop the vertigo and dizziness. We can even help with stabilize their hearing or give them a hearing aid, but then tinnitus can become kind of the more prominent feature at that point. As you are all aware, it happens at the brain level, or at least as far as we know, it doesn't, even though it's in relationship to the hearing loss in the ear, but it's actually not produced by the ear itself. So even if you treat the eye drops, they can still deal with this tinnitus for a long time afterwards. Ear fullness and pressure is also a vague symptom that is very common. This is thought to be due to the actual heart drops that happens inside the ear. If someone again initially presents and we're trying to diagnose them and they say, I feel like, I started after a trip or I was sick and then this happened, I got dizzy, I feel a pressure. It is obviously important to distinguish this from just a simple eustachian tube dysfunction secondary to, let's say, otitis media. Obviously, exam needs to be normal, but I will ask them to do a nasal valsalva to try to autoinsufflate their eardrums, or you can look at the tympanogram on the audiogram, and as long as it's type A and they can easily just pop their ears, then we say, okay, all right, this does not look like eustachian tube dysfunction. You likely have high drops, and then we would get an audiogram and hopefully catch it and establish the diagnosis. So this would also correlate with the attacks, and if the disease is well controlled, even if hearing doesn't come back up, oftentimes they say that, yeah, my pressure is better, my ear is not clogged anymore. So that would be a very good sign. In terms of management, the part that would be most important for our audiology team would be monitoring their hearing. And a lot of these patients end up getting hearing aids. So they will be seen intermittently by the physician or by the audiologist. And certainly, this would be kind of a teamwork that we would need to be in constant communication about these patients. Because if they go for a hearing aid adjustment and the hearing is down, the audiologist certainly will notify them like, hey, looks like you may have had a drop due to Meniere's and you need to go talk to the physician. And so certainly they need to be monitored. If you ever have one of these patients that come to you, let's say for hearing aids or for diagnostic audiology, then certainly counseling them about importance of monitoring hearing with serial audiograms would go a long way, because some patients, they don't like to do multiple audiograms, or if they just come for let's say check, they just want the ear checked for the thresholds, or they're in a rush. But it is certainly important to constantly monitor them. Even if they're fine, then we have a new baseline, or we know kind of how it's been behaving over the years. And if someone has a remote patient, if someone in a remote area, let's say in a rural area, they don't have access to an ENT or neurologist or even a certified audiologist, then these home hearing tests or cell phone tests can at least kind of help with a little bit with kind of either monitoring their trends or at least helping with establishing the diagnosis. And then we would also focus on treating them with medications, which we're going to go over those in a few minutes. And the treatment is focused on acute treatment when they're actually having an attack or a drop in hearing, and also long-term maintenance treatment. And finally comes in rehabilitation for both their balance and for their hearing loss. So right off the bat, we ask the patients to go on a low salt and caffeine diet. We usually recommend limiting salt to less than 1,500 milligrams a day, and also limiting coffee to a maximum of 8 ounces a day. And a lot of patients are, coffee lovers, and it's certainly a challenge. And some patients, especially if they have migraines, sometimes if they go off caffeine completely, they can actually have more symptoms. So certainly limiting these are fine. And if somebody wants to, let's say, have coffee, they can always have decaf or try to kind of mix and match to limit the amount of caffeine they take within 24 hours. In terms of medications, there are a number of medications that we would start these patients on. The mainstay of treatment are diuretics, typically hydrochlorothiazide, with or without triamtrene to help reduce the eye drops and reduce the sodium concentration within the inner ear, and also beta histine. If someone presents just with the eye drops, which is the fluctuating hearing loss and the low frequency hearing loss without any vertigo or dizziness, I may sometimes not start them on beta histine and just do diuretic. But if they have vertigo and dizziness, we would certainly start them on beta histine as well. In the United States, beta histine is a compound medication. patients who travel Canada, Mexico, or people who live in Europe, they can often buy it from a pharmacy as a commercial medication, but here it has to be compounded. So these together kind of help stabilize the disease in a majority of patients, but certainly there are patients who are resistant. For the acute phase, when they are having a sudden drop in hearing, steroids play a role. Initially, we would offer them oral steroids, usually prednisone in high doses. And if that is not effective, then we would start them on intratympanic steroid injections. And then for acute vertigo and dizzy spells, then initially we would recommend meclizine, which is also an over-the-counter motion or seasickness or motion sickness medication. And if that is not effective, then diazepam or Valium would be the next option to offer them. In terms of the injections, there are two kinds of injections that are done for these patients. You might have had patients who've had these before, steroids and gentamicin. Looking at the literature, the success rate is roughly about the same. Most people do the steroid injections because it is not a destructive procedure. Then gentamicin is injected with the intention to essentially kill the vestibular system within the inner ear. So it is considered a destructive procedure. And one historic concern with these is that, well, what if they get the Meniers in their other ear? So that's always a consideration. So some people would offer them gentamicin, especially for resistant patients who do not respond to anything else, and especially in patients who may not have a great hearing. I personally try to essentially just do the intratympanic steroid injections and very limited cases of gentamicin that I might offer, but for the most part, I try to avoid that. But it is certainly an option, and some people prefer that actually for right off the bat. Some of you might have seen the injection. So this is kind of how we do it. Usually we use a long needle and sometimes a spinal needle, and we numb a part of the tympanic membrane and inject dexamethasone. And usually we do a minimum of 2 or maximum 4 injections. Now, between different neurologists or different ENTs, there might be slightly variable protocols, but in essence, you want to do at least a couple to a few injections, and usually these are 5 to 7 days apart. And even though we're trying to treat Meniere's, which happens at the inner ear, as of now, we don't have a reliable way of injecting directly into the inner ear. So when patients come in for intratympanic injections, we're actually injecting it just behind their eardrum into the middle ear, and we kind of fill it up. And the hope is that through the round window membrane, it is absorbed. And there are a lot of studies, including animal studies, that actually have demonstrated that when you do injection, actually concentration of steroid within the cochlea over time goes up and can stay up to 7 days. So we do know that it works, but point being, essentially, we're injecting this into the middle ear. And as you know, the eustachian tube is there, and sometimes you have a lot of pneumatization within the temporal bone, and they have very prominent cochlear air cells that lead to petrous apex, and some of the medicine might actually drain in that direction. So usually when we inject, we try to completely fill up the middle ear and also have the patients kind of lay back, and we place them in a certain position to minimize the chances of it draining and maximizing the chances of the steroid being absorbed. So if a patient does not respond to the typical treatments, then we start talking to them about surgeries. There are 3 main surgeries that are available for these patients. Endolymphatic sac surgery, which could be with or without shunt placement, labyrinthectomy, and also vestibular nerve section. The first one, it is considered a non-destructive surgery where we can offer this to patients with normal hearing or with good hearing. And the number 2 and number 3 are considered destructive procedures. The labyrinthectomy would result in complete loss of hearing, so it is usually reserved for patients with pretty much severe to profound hearing loss with no meaningful word recognition. And these days, we actually try to simultaneously place a cochlear implant. Obviously, if uh, health insurance plans approve it, but these patients would certainly benefit from that because they either have a poor hearing or they're going to lose whatever hearing they have left. So a simultaneous implantation with a cochlear implant could essentially kill two birds with one stone. You would help them with resolving their vertigo attacks and also try to bring some of their hearing back. And the vestibular nerve section, technically is not supposed to damage hearing. However, not in every patient, the um line between the vestibular portion and the cochlear portion of the vestibulocochlear nerve is not as clear. So when you are, I mean, there are little tricks and tips that we know, and based on their location and the kind of slight differences in their appearance, that we try to cut the vestibular nerve. However, to make sure that you actually got all of the fibers, you may need to cut a little bit of the cochlear nerve too. So there's always a chance of hearing getting slightly worse. So it is technically considered a destructive procedure, at least from the vestibular standpoint. And the significance of it is that if a patient develops contralateral Meniere's down the line, you cannot repeat this on the other side. Otherwise, they will have bilateral vestibular hypofunction. Then that, as you guys know, will be very debilitating, and they will have very serious issues with walking and maintaining their balance. So this is how we do an endolymphatic sac surgery. The kind of the anatomy might look a little bit different, but this is essentially a mastoid bone. Let me see if I can turn the laser pointer on. So this would be anterior. This would be superior, inferior, and posterior. So your external auditory canal would be right about here. This is the mastoid one. We would drill it, identify the semicircular canals, and there are some landmarks that we use, but in essence, the endolymphatic sac would be underneath the facial nerve and inferior to the posterior semicircular canal. And this area is opened up. And in essence, we're opening the dura, we're decompressing the dura. And the lymphatic sac is sitting on dura and is a part of dura, not technically dura, but essentially adherent. So when we open it up, we kind of can determine where the sac is by looking at the direction of the fibers and the appearance of it. Sometimes it's clear cut, sometimes it's not. And there are two ways of doing this surgery. One is to just open it up, decompress it, and sometimes people would use electrocautery to um, uh, maybe kill the cells within the sac, or if it is pretty obvious where it is, then it can be opened up and a piece of silicone could be placed as a shunt. But one, as a surgeon, we know we need to be careful. We're actually not piercing the dura because then you would get a CSF leak, which is cerebrospinal fluid, and that will be very bad. Those patients most likely will require a bigger surgery to repair that leak and the connection between the brain space and the ear. For labyrinthectomy, it's kind of, again, the same thing. We would open the mastoid, but then instead of preserving the semicircular canals, we would just drill them and expose their, copula and expose the vestibule and try to remove the saccule and utricle and all the vestibular apparatus. And we would then plug it with various tissues and different methods. But at the same time, they can also get a cochlear implant if it is approved, or if they wish to get that. So this is kind of how the surgery is done. In the lymphatic sac surgery, usually we send them home, but for labyrinthectomy, because they might still have some vestibular function, by removing it, we are giving them, in essence, an acute vestibular loss. So oftentimes they're going to have um, severe balance issues, dizziness, or even vertigo. They're going to have an nystagmus that can improve over the next few to several days. So they would oftentimes stay in the hospital for at least a night or two before they are discharged. As for the vestibular nerve section, this is a craniotomy. We do these with our neurosurgeon, and there are different ways of doing it, but in essence, we want to open up what is called the cerebellopontine angle, identify the porus acousticus, where the cochleovestibular nerve exits, and then the facial nerve is also there. So we need to identify the facial nerve and then see if we can identify the division between the vestibular and the cochlear nerves, which oftentimes could be difficult. And once we identify, then the vestibular nerve is severed. And again, this would have a very high success rate if done properly and if done for the correct patient. And even though hearing could be damaged a little bit, the intention is to preserve hearing. So this could be offered to someone with excellent hearing with and severe vertigo that does not respond to treatment. Then comes rehabilitation. So whether we control the symptoms or if they're resistant, still we need to address their ongoing issues. In between vertigo attacks, they can have balance problems because usually with each attack, they can lose a little bit of a vestibular function. So for their balance issues, we would recommend vestibular therapy. In terms of their uh, hearing function, then depending on the degree and type of hearing loss, then we have the options of hearing aids, bone conduction devices, or a cochlear implant. Vestibular therapy is usually done by a certified physical therapist. They do a minimum of 6 weeks of treatments. Patients would have specialized treatments. This does not help with the acute phase of the vertigo. Sometimes patients come to us having already done the vestibular therapy and they say, yeah, it didn't help. If someone is having active vertigo and they experience hours of or minutes or hours of spontaneous vertigo, this is not going to help with that. It is usually for patients that we've been able to control their vertigo, but they're now having some, balance problems or sometimes they just get kind of few or quick, episodes of dizziness when turning their head, or some of these are professionals, they, work on machines, or they need to be in certain positions, and that would trigger, a little bit of dizziness, and certainly vestibular therapy can help with that. But this is not intended for the acute phase of the disease or for the vertigo attack. So again, in essence, it is a kind of a rehabilitation for these patients. And then in terms of hearing loss, we would look at their hearing thresholds, their pure tone average, and their word recognition scores. And American Academy of Otolaryngology Head and Neck Surgery has a classification, class A, B, C, D. Not super important to memorize it. Obviously, we do know it, but on a daily basis, when you see these patients, or as audiologists, when you evaluate these patients, uh, in essence, we need to see if they're a class D or not. And class D, they can have any kind of levels of pure tone average, or any levels of hearing thresholds, but the word recognition score needs to be less than a 50%. And as most of you are aware, if someone has, let's say, a 42% word recognition score, I mean, yes, they're understanding 42% of the words, but they're doing a lot of guessing. And if you can certainly try hearing aid. We always recommend that they try a simple hearing aid. That might be good enough for a patient, may not be good for them, but it never harms to at least try a regular conventional hearing aid. But for the most part, we know that they're not probably going to like it because everything will sound distorted. The clarity is not going to be there, even though hearing aid can amplify and provide them with volume. But if their word recognition score is, let's say, 80%, excellent candidates for hearing aids should certainly be considered. So I would say for anyone with hearing or with a word recognition score above 50%, I 100% recommend trying hearing aids first. If it's less than 50%, I would say it depends. If it's like barely under 50%, like 46%, I think it is still worth a shot. But if it's like 20%, they're probably not going to like it. But again, it certainly does not harm to try it. And if they are considering a whole cochlear implant, oftentimes, the insurance plans want to see that they have tried a hearing aid first before, we can submit for authorization and evaluate them for implantation. And I'm sure there will be many talks, or you have been to many talks, and a lot of you are potentially working with hearing aids. So they come in different shapes and forms and brands and qualities. And this is not something that we would get into with the patients, but we briefly mentioned the different kinds and the options, and we would then refer them to audiologists for evaluation and fitting with hearing aids. Now, If someone has serviceable hearing, again, word recognition score better than 50%, certainly a conventional hearing aid is going to be a good option. If it is lower than that, or if they do not benefit from a conventional hearing aid, then we can counsel them about cross hearing aids, which, as you are familiar with, it would cross the sounds coming. Let's say if the left side is the affected side, and let's say they only have like 12% word understanding, severe to profound hearing loss, and let's say they don't want to do surgery or they don't qualify for surgery, then with the cross aid, they will hear people talking on their left side in their right ear. So this would certainly help with improving their quality of life. If someone has, again, a lot of hearing loss to the point that that ear is not serviceable, but let's say it's a young patient and the other ear has normal hearing, then certainly bone-anchored hearing devices could be considered. There are a number of them out there. I'm not sure if there's going to be a talk on that or not, but a lot of you likely are familiar with the different kinds and different brands. So any of them is fine. And the idea is that if someone has a normal hearing, they may not like the cross hearing aids because that usually requires wearing a hearing aid in their good ear. And sometimes the cost is prohibitive. A pair could be a few $1,000s, but this is usually the bone anchored hearing devices are usually covered by insurance. If someone is young and has normal hearing in their good ear, I think this is a very reasonable option that will help them hear sounds coming from the affected side and helping them hear them in their good side. So we would certainly counsel them about these kinds of hearing aids. And finally, cochlear implants, as I mentioned, would be a very good option for later stages of the disease when the hearing is pretty much gone. And if we are planning for labyrinthectomy, we would certainly want the patient to be considered. Now, if they have a lot of hearing loss in their good ear too, if it's an older patient, obviously most insurance plans would approve it. But if it's a younger patient or even an older patient with, let's say, a really good hearing and then the affected side that hearing has been completely lost, as you are most likely aware, not insurance plans are going to approve it, including Medicare. So then this may not be an option. But if we are doing a labyrinthectomy, I think certainly this should be considered as an option for these patients. All right, so with that, I'm going to wrap up this talk. So in summary, Meniere's disease is a chronic inner ear disorder with episodic vertigo, tinnitus, hearing loss, and ear fullness. The diagnosis is mainly clinical, and it is supported by audiometry and vestibular testing. And imaging studies can certainly be done to rule out other conditions. And in select patients, even as a specific hydrops protocol could be done to detect the hydrops. And the treatment options range from simple dietary and lifestyle modifications all the way to medications, injections, and the surgeries that we reviewed. All right, so with that, I'm going to close this and I'm happy to take any questions.
I think there's a couple of Q&A questions.
Yeah, I see that there. Has there been any research done into why there is a female preponderance?
Not that I know of. I mean, the difference is not that significant. So if a condition is like, let's say let's say a certain condition happens in males or females, like 80% to 20%, I think that that is worth looking into. But that's why we say preponderance, because it's just a slight kind of preference towards, let's say, females. We don't know. Could be a connection with migraine, but it's a long shot. We don't know, and I'm not aware of any meaningful evidence that has provided why, and certainly it doesn't run in families. So even though some studies have looked into potential, genes involved, nothing has been definitively found to kind of predict occurrence of Meniere. So we don't know.
Another question from Chuck Schultz. Why is beta histamine a compound only drug in the US?
That's probably above my pay grade. As far as I know, it's an old medication. It's been around for a long time, and it doesn't have FDA approval for any particular conditions. I think that's maybe why it's not produced commercially, and I think no one owns the kind of the trademark. So it probably doesn't make sense for the pharmaceutical companies to make it. You can certainly get it compounded in the United States. Some patients actually ordered from Canada. We just send the prescription to Canada and it gets shipped to them. Uh, but with the tariffs and with all the issues going on, we've had some issues with that. And also sometimes the ones in Canada run out, and then all of a sudden patients tell us that they're getting like packages made in UK, and then all of a sudden their symptoms are worse. So there has been a little bit of an inconsistency in that regard. So anytime we can, we try to just have the patients buy it locally from compound pharmacy, and that certainly has.
Right. Another question, how often is partnering with a mental health provider considered for someone with Meniere's disease?
Um, Certainly, we would consider that for some patients. I would say majority, because they already improve with the medications and the symptoms stabilize, they don't need it. But I would certainly consider it for someone with resistant disease that they're not responding. Obviously, it's affecting their life. Often these patients go on long-term disability. They can have mental health issues, so certainly would consider it for someone like that. Another situation where I think that could be useful is if someone has debilitating tinnitus or a lot of hearing loss, and let's say we do an implant. Let's say the implant doesn't work, or if it does work, but now they're getting it in the other side, and obviously that would be, debilitating to anyone. So I think in those situations, certainly it would be helpful. We do know a couple practices that they specialize kind of in helping these patients. So I do often send these patients to those mental health providers. So certainly something to consider in select patients, but I don't think it's something that the majority of patients need.
Okay, if a person is having these symptoms, do you as an ENT always do an MRI to rule out an acoustic neuroma?
Pretty much, because they, in essence, have an asymmetric hearing loss, which could be a feature of vestibular schwannoma. Uh, they can have vertigo or just dizziness. Again, could be a feature of that. So I personally recommend it. And it is pretty much recommended to order that. Now, sometimes patients come to us with a history of Meniere's. They've already responded to the treatment, but they never had an MRI. I probably wouldn't order it in that particular patient, because if it's a tumor, it's not going to fluctuate. I mean, vertigo sure can happen, unless it's a rapidly growing tumor. Usually, it's just maybe wake dizziness, and just progressive hearing loss. But if the hearing is fluctuating or they respond to the treatments, you can pretty much rule out acoustic neuroma by that. But uh, as a tertiary, referral center, I tend to just order it, because we certainly do not want to miss an acoustic neuroma, and a patient goes on years without proper diagnosis, and then by the time it's found, it's grown to a really large size and causes problems. So I would personally get an MRI for any of these patients.
Why can't electrocochleography be part of diagnostic criteria?
Um, well, it is not, because at least it hasn't been established by our academy to recommend it to everyone, and to do ECOG, it's a little bit obviously uh, labor intensive and could potentially be a little bit invasive for the patient. And the other issue is just to getting it approved by insurance companies. Uh,
Right.
so that's probably like the biggest part of it. So because it's not a part of the established standard of care, we sometimes do it for our research projects, but that would require a different kind of, consent process, and then they're subjects, not patients anymore. But kind of how medicine works, at least we haven't found it to be needed. And even MRI, we're not doing it for the purposes of seeing high drops. It's just to rule out an acoustic neuroma. And same
Right.
with ENG, even though it can help and it's a much simpler test and often gets approved if you order it, still doesn't really help much, at least for a typical patient. So we would reserve it for select patients only.
What are some of the long-term negative side effects of standard medications used for treating Meniere's disease?
Right. So the diuretic, hydrochlorothiazide has been around for decades. It's a known medication that used to be one of the main treatments for high blood pressure and still is used as, I think, second or third line. Most patients do well. Obviously, some patients, if they have a low blood pressure, they can get lightheaded or dehydrated. So these are usually found out right after. And some of these patients can actually have kidney problems. I've had at least a couple patients. It is rare, but it can happen that they've developed like acute kidney injury. So when we start them, we usually kind of try to monitor them. I don't personally order labs. Some of other associates, they start them on pure hydrochlorothiazide. And if you do that, you need to monitor their potassium levels. But with the triamtrene hydrochlorothiazide, that's not as needed. I just allow or ask their primary care physicians to kind of monitor it periodically. So that's the main long-term risk with the diuretic. The beta histine is pretty much well tolerated. You're either allergic to it or not. Some people, especially if they have a low kind of body weight, they can feel like stomach upset or flushing or kind of allergy type symptoms, and then we may need to reduce that. Steroids, if we need to do it frequently, obviously, as you know, they can have really bad long-term side effects. So if someone looks like that they're going to need multiple treatments with steroid, we try to alternate between oral and injections, or if they truly need long-term steroids, we would send them to a rheumatologist to find alternatives for that.
Right. How many patients, Meniere's patients, do you see per year? Because as an audiologist, I don't see as many Meniere's patients now as I did decades ago.
I may be biased because, we're a tertiary referral center and we see patients referred to us by other ENTs. So as I said, there's not a single clinic day that I don't have a Meniere's patient. And just in terms of even getting new patients, it is still a very common problem. I probably get at least 3 or 4 new Meniere's patients every week. So it is very common. We see it
Wow.
very commonly.
Um, I got one more here. Does reducing salt intake reduce symptoms significantly for patients you've seen, or is that more of a general or outdated recommendation?
It is, I would say, more of a general recommendation. However, there are patients who are sensitive to salt. So when I mention salt, or as I keep seeing these patients, and they were doing so good, everything was fine. They went to Vegas, it was the Father's Day, they went to a buffet, and then they had a lot of salty foods, and all of a sudden they had an attack. So there are some patients you actually see that clearly happen after ingestion of large amounts of salt, but it is not something that happens in every patient. But as of now, we don't have a good way of predicting who's gonna be sensitive and who is not going to be sensitive. So we just generally recommend to limit it to less than 1,500 milligrams of salt a day.
How does caffeine trigger Meniere's symptoms?
We don't exactly know, but it must, it could be just affecting the blood vessels within the inner ear and helping with whatever causes the high drops, which we still don't understand very well. And most patients are not going to be sensitive, just like salt, but there will be clear patients that they are going to say, yeah, anytime like I have a cup of coffee, or if I drink 2 cups, and I forget about my Meniere's, then all of a sudden, my ear will start feeling clogged. So those patients, I would say they should avoid it. I mention it to the patients, but I don't like check on them every time they come back if they've been avoiding it. But if they've had an attack, I always ask them, hey, did you take anything that could have triggered this? And we try to kind of tell them what possible risk factors. And if they also have simultaneous migraine, we also kind of give them a migraine handle with everything that they're supposed to be avoiding. And if we find a clear triggered, then I certainly want them to avoid that. But for most patients, it's not like they're 100% sensitive. So as long as they can limit their coffee, I'm okay with that, and I don't forbid it or anything like that.
Well, yeah, this is something I've always wondered too. Why is it typically only a low frequency hearing loss?
That's a good question. We think it's the high drops affecting the areas of the cochlea that the low frequency hair cells are, which are farther apart. And it might be because as you move towards the areas that kind of the low frequencies are processed, it kind of becomes a little bit narrower and smaller. So it could be that there's just more pressure pressed on that. But kind of a lot of it goes into the fact that we just don't know. We don't know what happens, and even the high drops that has been observed. I mean, nowadays we see it on the MRIs, but for the longest time we only knew about it from postmortem dissections. Interestingly, a few of my patients who have actually had that MRI with high drops protocol, they've had it on both sides, so actually creates more questions and problems. So just last month, I had a patient with left-sided Meniere's disease. Right side was completely normal. Really wanted to see if he truly has hydrops. I guess he was questioning diagnosis, but it was responding to treatment. I ordered it because we needed an MRI anyway. They might as well get it with the hydrops protocol. I don't mind it. And the report came back. Sure, they had high drops in their affected ear, but they had more high drops in the other ear. Now that kind of opened kind of can of worms. Oh my gosh, what am I going to do? Am I going to get it on the other side? So there's not a direct correlation in terms of whether you have high drops and Meniere's, even though there is an association, but certainly more research needs to be done. And a lot of these patients, actually, we don't see the high drops on their MRI protocol. The inner ear is very small, and we don't have a reliable way of imaging it in live patients. And there's not a good way of biopsying the inner ear or taking an inner ear fluid sample. The only time we can do that is if we are doing a stapedectomy or cochlear implant and we get a little bit of a perilymph leak. And even then, you cannot really sample endolymph. So a lot of unknown about it that we don't know, but something that if we ever see a patient just with low frequency hearing loss and it hasn't been fluctuating, I always mention the possibility of high drops, because I don't know if I'm going to see them again, but if I always tell them like, hey, sometimes could be high drops. So if it starts fluctuating or progressing, come back and let's talk again. So certainly a feature, but we don't exactly know why.
What are some of the long-term negative side effects of certain medications used for treating Meniere's disease?
I think we just answered this, didn't we? Might be an old question.
Maybe the youngest age you've ever seen a Meniere's patient?
18 years old, youngest.
Well, okay, I think that pretty much wraps it up. We're going to call it a day here. And thank you so much, Doctor. I really appreciate your time, your information. It was very valuable. I think based on all the questions you see here, people were really listening and paying attention.
Thank you so much for having me. Have a good night, everyone.
Thank you.